Well, this is good timing, Prem, because we have an interventional cardiologist talking next. And so we're very fortunate to have JD Schwalm, who is one of the bright young researchers in our group who focuses on health system research, but also KT. And obviously had a big splash this summer with Hope for ESC and also Lancet. So looking forward to hearing your talk, JD.
Thanks, PJ. So good afternoon, everyone. It's a pleasure to present. Sorry, skipping through there. Integrated health systems to translate evidence into practice. I'd like to use the example of cardiovascular risk and particularly hypertension to drive home a few key points. So hypertension, as we know, leading cause of cardiovascular disease worldwide. There's clear evidence that lowering blood pressure will reduce cardiovascular disease and mortality. Unfortunately, as we've already seen, hypertension detection, treatment, and control is low globally. It has been demonstrated that statins reduce cardiovascular disease in those with hypertension, as per the ASCOT and HOPE-3 study as well. But unfortunately, their use is very low, at less than 5% in this patient population. Combined blood pressure and LDL lowering medications has the potential to reduce cardiovascular events, as we've seen, by more than 50%. But how can we optimize health systems in order to reduce this evidence practice gap? So that's what I'm going to touch on today. I'm not going to belabor and kind of go back over some of these strategies that we've already heard. And these include non-physician health workers, community health workers, and task sharing. There is evidence for them, strong evidence in other fields of medicine like HIV, newer evidence in cardiovascular disease and hypertension. I'd like to emphasize easy access to free medications, or whether we say barrier-free access to medications. I think that's important. We've seen evidence with respect to the combination medications, including the poly pill. There's been a mention of treatment supporters, and these are friends or family, personal coaches involved to help medication adherence. And then we can't forget mobile health technologies. All of these kind of thinking outside the box of our normal health systems and how can we pull these together. So I think I do have to pause and say that there are many studies that support these different community-based interventions for the management of hypertension and cardiovascular risk. But there are also many studies that fail to demonstrate the benefit. And we have to ask, why is it that so many studies are neutral or negative in this area? And I think we have to think that cardiovascular risk is a complex issue. There's many factors facilitating or inhibiting optimal care. And this is something that we need to think, if there's multiple barriers limiting optimal care, this is an example, may be the NPHW, as was mentioned, may diagnose hypertension, but they may not be able to prescribe the medications. There may not be availability of medications. And so it's trying to facilitate and target all these issues. Sorry, I'm slipping forward here. So that brings us to the HOPE-4 study. And I'd like to present this on behalf of the co-authors. I'm not sure why this is timing forward there, sorry. So on behalf of the co-authors, to illustrate how health strategies that target identified barriers to care can effectively translate evidence into practice. So with the HOPE-4 study, the goal was to improve the control of hypertension and cardiovascular risk in the community, and I think that's key. To achieve this goal, we first conducted systematic reviews and health system appraisals to identify contextual barriers to care in Colombia and Malaysia. This work then informed a comprehensive intervention that was designed with 3 core components that I'll touch on. We then evaluated this in a pragmatic cluster randomized controlled trial. So the HOPE-4 intervention components were designed to overcome identified barriers at the patient, healthcare provider, and at the health system level. And through these identified barriers, and one was mentioned earlier today, that the beliefs of the patient are in alternative therapies that may be conflicting with medication use, this had to be overcome. And so education in our intervention was tailored to target this. Other things are fragmentation within the healthcare system. So that continuity of care that we hope exists just doesn't. And so tying this together. So with that, we found 3 core components were essential to target these barriers that were identified. These include task sharing with non-physician health workers. And these were out in the community. They identified and treated hypertension and cardiovascular risk. We also provided free cardiovascular medication, and these were a combination medication. They weren't a complete poly pill. There were two medications, one single statin, and then a combination antihypertensive, given the evidence. And then finally, we need to enhance adherence. You can give somebody a pill, but will they take it? Will they have the effect? And so we needed to figure out a way to do this, and that's the involving friends and family to support with respect to this. So the non-physician health workers in the HOPE4 study all completed a 1-week, 9-module curriculum on CVD risk assessment and management. This curriculum has been adapted to the World Health Organization's HEARTS technical package to improve the management of cardiovascular disease in primary health care. The study itself, we screened 4,000 patients, almost 5,000 patients across 15 communities in Malaysia and 15 communities in Colombia. There were 1,900 that were eligible, and we consented over 1,300. We had a 97% follow-up with respect to the primary outcome at 12 months, with 16 communities randomized to control and 14 to intervention. Just to give you an idea of the participants in this study, the mean age of the study population was 65 years old. They were just over half female, less than 10% were smokers, and a third with diabetes. And it's important to note that despite over 2/3 of the participants taking antihypertensives at baseline, and 20% taking 2 or more antihypertensives, the mean systolic blood pressure was still over 150 in both groups. There was no significant differences between cholesterol and glucose. So as was mentioned, the non-physician health workers were found to be consistently accurate. And I think this is really important when we're thinking of working outside of the traditional kind of health system. There was 99% agreement in their ability to identify cardiovascular risk, 98% with respect to the identification of cardiovascular medication contraindications, and 93% agreement with respect to their treatment recommendations. We also saw that the participants attended 94% of the scheduled visits, so there's fidelity to the intervention. Treatment supporters were present at 74% of the visits in the intervention group, the majority of these being family members. So additionally, 84% of the participants in the intervention group were taking 2 or more antihypertensive medications, as compared to 65% in the control group at 12 months. Statin use was significantly higher at 84% in the intervention group versus 38% in the control. And it's also important that medication adherence to antihypertensives was 50% greater in the intervention group. So this is key. Not only were they taking 2 or more antihypertensives, statins, they were also more adherent to their medications. In those who received the intervention, the Framingham 10-year risk estimate, which was our primary outcome, dropped by an absolute 11.2% compared to 6.4% in the control. This consistent with more than 40% greater reduction, which we're pleased to see. If we look at this with respect to the efficacy of the primary outcome, it was consistent across all predefined subgroups. So importantly, the intervention was effective in 2 different countries, on 2 different continents, with 2 different health systems. Furthermore, the HOPE4 intervention worked in both urban and rural, men and women, young and old, and all at varying education levels. When we look at blood pressure, there was an absolute 69% increase in blood pressure control status in the intervention group at 12 months, more than double that of usual care. If we look at the individual outcomes of blood pressure and cholesterol lowering, there was a greater absolute reduction in both systolic blood pressure by over 11 millimeters of mercury at 6 and 12 months, and a 0.4 millimole per liter greater decrease in LDL in the intervention group as compared to control. So this table highlights the trend to benefit in most health behaviors when we talk about lifestyle recommendations in the intervention group, resulting in substantial reductions in the non-lab-based inner heart risk score. In particular, there was significant reductions significant increases in physical activity, daily vegetable intake, as well as significant reductions in salt intake. There was no change in smoking, weight, stress, or depression. So a comprehensive model of care led by non-physician health workers involving primary care physicians and family, along with the provision of free combination antihypertensive medications, a statin, as well as a statin, improved blood pressure and cardiovascular disease risk. The hope for non-physician health worker-led intervention was successful because of four real key reasons, and that's that it simultaneously addressed multiple barriers to cardiovascular risk. It was community-based intervention adapted to the local context within Colombia and Malaysia. And I think that's key. It's not involving patients that are already within the healthcare system. This was out in the community. We reinforced adherence involving family members formally involved in this. And we had comprehensive intervention where these non-physician health workers were supported by mHealth tablets and had simplified algorithms for their management. So as mentioned, we do feel as well, like the polyaram study, that this adaptation of the Hope For strategy to specific contexts and their widespread implementation, including community screening, can achieve the United Nations General Assembly plan for a 1/3 reduction in premature mortality from CVD. I do want to touch on this very briefly, but what about implementation in a high-income country? We did look at this and adapted the Hope For study to the Canadian context. We implemented similar components used in the international study, but we did not supply free antihypertensives or statin within this community-based pre-post pilot interventional study. We did, however, try to use non-physician health workers that were already working within the infrastructures in Canada. So in Surrey, BC, we used firefighters that were involved in community programs where they'd go in and check the fire alarms within houses to see if they're safe, and then at the same time, they'd assess for cardiovascular risk and make recommendations. In Hamilton, we work with the Urban Core Community Health Center in the inner city to try to reach out to communities at risk. We included the same population as Hope For with patients over 50 with new or uncontrolled hypertension, and our outcomes were similar, but again, it was a pilot study. So really the key points are there's similar trends as the larger study. Similar to Hope For International study, there was an absolute 17 mm drop in the systolic blood pressure and a 51% absolute improvement in blood pressure control. Again, this is pre-post, but at 6 months. We also saw that there are similar trends noted in the international study with statistically significant reductions in the Framingham risk score between baseline and follow-up. The trends and other outcomes were favorable, but not significant. So unfortunately, the study implementation, and this is part of our barriers, is that it was limited by competing health priorities in Surrey, BC, which cut things a bit short. And there was a fentanyl epidemic kind of within the community in which reallocation of funds kind of diverted our first responders. So I think there are some important considerations from the Hope For intervention. And I think one, it requires non-physician health workers. And this is a labor task force that may be new to certain countries. It may be that they already exist and we can retrain from other areas like maternal health or HIV. Or in higher income countries, it has been explored with other avenues like, as I mentioned, firefighters, paramedics have been looked at as well, and then volunteer teams. Our current study had a cardiovascular and hypertensive focus, and I think there is a need to adapt and expand the intervention to other health priorities. This could include diabetes, COPD, cancer screening. Finally, we had mobile health tablets with decision support, which was a key component of the intervention supporting these non-physician health workers. And this is a great tool, but there is a cost to maintenance and an infrastructure that's required. And the last point is we did use locally sourced medications in both Colombia and Malaysia. These were provided free to our participants. And I think the key thing is that many countries do actually provide a subsidy for medications, but it's the barrier to get them. So it's the day off work to travel and go and get these medications. That's the barrier for a condition that may be asymptomatic, that they have to go back the next month for refills. So these are things that we need to look towards, is to removing these barriers. So I just wanted to touch on briefly what's happening now. So and this is on behalf of our colleagues in Colombia and Malaysia. So Dr. Patricia Lopez Jaramillo, who's here today and can correct us in the panel discussion, but I did take a few points from his notes. And right now there's been dissemination of the HOPE4 findings in Latin America with conferences to medical doctors, with over 550 primary care and specialists being educated about HOPE4 and the strategies involved. There's been meetings with respect to policy and implementation with the Minister of Health and their team in Peru and the Dominican Republic as well. It's been a comment that there is a need to kind of bring in more of the non-physician health worker into the HARTS implementation packages. That's not the case across all countries involved. There's been discussions with the Minister of Health in Colombia with plans to implement HOPE4 in one of the cities where there is universal health care. There's been collaborations built between insurance companies, as this is an alternate avenue to get out there and improve adherence and reduce risk. There's also been discussions with the Secretary of Health locally where the study was undertaken in Bucaramanga, and health teams in the Santander department, where they hope to continue follow-up within the HOPE4 communities. Finally, funding is being sought for further implementation, and this is both locally and abroad to maintain this strategy and adapt it further. In Malaysia, Dr. Yusoff has had a meeting with the head of the NCD division in the Ministry of Health, and they had a workshop along with the co-investigators of HOPE4, as well as 4 other universities, and it's clear there's a need for HOPE4 to be put into clinical practice. They need to develop these IT links, use it with the tablets between non-physician health workers and their family medicine specialists. They do wish to adapt the implementation a bit and think about volunteers that they would use. And they've got, I guess, a large group of retirees and pensioners who are keen to kind of undertake this. They do have availability from government clinics with combination medications, antihypertensives, sorry. And there's an agreement to get started in 35 clinics with 50 participants across 4 states as an initial step. They've also had meetings, or are going to have meetings at the end of November at local hypertension conferences involving other countries as well that have interest, potentially linking us to further other countries and low and middle income countries. So just to kind of finish off, I think we do have barriers in HOPE4. We had an extensive approach evaluating the barriers to help define our intervention. And I think that this is something that does need to happen, but it is going to be tough to implement in all these countries if we do want to expand and implement. And so we do need to kind of simplify this approach, and that's something that we've been working and talking, early discussions with Martin McKee and his group regarding kind of an approach to this. I think we need to build on collaborations that we have, and this would include international collaborations, which we're planning a teleconference for later this month with the WHF and the WHO, along with other key collaborators. We also need to involve things locally, so our own hospital corporation, family medicine experts, nurses, to kind of describe how can we get this implemented, not just abroad, but also locally here, what needs to be done. I don't feel that we're necessarily in a place where we need to keep repeating cluster randomized controlled trials everywhere. I do think that there's enough evidence for these components that if it's thoughtfully tailored to the context, then simple kind of pre-post implementation to ensure there's fidelity and uptake, I think would be reasonable, but that's up for discussion depending on the context. I just wanted to finish off and say thanks to the HOPE4 team, which has been a very exciting time, and all the help that we've had both locally and abroad. So thanks very much.